From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hello, and welcome to our listeners from around the world. I'm Paul Bryson, your media editor for JAMA Oto, and welcome back to our JAMA Oto podcast. Today, I'm delighted to be joined by Dr. Nyssa Farrell and Dr. Lara Crock, both from Washington University in St. Louis. Dr. Farrell is an otolaryngologist, head and neck surgeon, and Dr. Crock is a pain management specialist in the Department of Anesthesiology. Welcome, both of you, to the podcast.
Thanks for having us.
Thanks for having us.
Well, I'm excited today. I wanted to congratulate you and then also discuss your work on stellate ganglion block for the treatment of COVID-19 induced parosmia. As you can imagine, this has been a pretty hot topic, and we've seen a lot of stuff in the press. And, one of the really great things about this work that you've done is that it's actually a randomized controlled trial. And this is not something that we see very often. So I wanted to just get started. I'll direct this first question to Dr. Farrell. Tell me a little bit about how you were able to approach this project and how you were able to kind of organize and pull it off.
Yeah, so, here at WashU, we've been very involved with COVID-mediated olfactory dysfunction. And we've been working pretty tirelessly since the pandemic started to try to find some treatment for COVID-mediated olfactory dysfunction. As we've been going through that, one of the things that we've actively done is watched the media and social media to see what people have talked about, to see are there things that people are finding in the community that maybe we're not necessarily hearing about early on. And to that end, we heard about stellate ganglion block. And Dr. Crock already knew about it because she does stellate ganglion block for non-olfactory indications. But for me, it was something I'd never even heard of before. And it was getting tons and tons of social media attention. People were telling really phenomenal stories about how they hadn't tasted a Reese's cup in 3 years. And then they got a stellate ganglion block. And within seconds, they were crying with happiness because they could eat a Reese's or they could smell the grass or whatever it was. And it was this very profound impact that they were describing. From a otolaryngology perspective, it didn't make a lot of sense to me. I didn't really understand it, but I'm not sad if I hear that there's something that might work. And so our team here started looking into it a little bit more. And that's when I met Dr. Crock and found out that she's actually an expert in stellate ganglion block.
Yeah, and I'm in the same boat as you. Let me take a step back. Dr. Crock, can you tell us, just give, for the listener and for me, a little background on when do you typically perform stellate ganglion blocks, and maybe just a brief little background on the procedure?
Sure, yeah. So stellate ganglion blocks have been performed for almost 100 years now for different conditions, oftentimes for facial pain. The most common indication for stellate ganglion blocks is actually what's called complex regional pain syndrome, which is something that I specialize in. It's a pain condition can affect any limb, but for stellate ganglion blocks, we use it to treat upper limb pain. It's a horrible condition, and there's some thought that blocking the sympathetic mediated pain can help with that pain condition. And patients find some benefit from these blocks when paired with specialized physical therapy. Stellate ganglion blocks have also been used commonly for things like post-traumatic stress disorder. This is a less common use for it as it's not covered by insurance, but the VA actually does use stellate ganglion blocks quite often for the treatment of PTSD because they clearly have a large need for the treatment of PTSD. And so for these reasons, it's something that as pain management physicians, we do quite frequently. And I'll say there was a study that Dr. Farrell and I had read that came from Korea that had used these blocks for parosmia or anosmia back in 2013 for a different respiratory virus that had caused some olfactory dysfunction. And so that also gave us some indication that perhaps this was a viable treatment and not just some crazy idea.
So as you approach this study, prior to doing the study, had you been performing the blockade for parosmia or other olfactory dysfunction? Or was this kind of like, I know this article from Korea and I hear about this in the press, and Tell us about the design of the study.
Yeah, so I know from my end, so I'm a rhinologist, I specialize in olfaction. I was getting tons and tons of referrals from the community for people asking for stellate ganglion block, even though that is not something that I perform. And as I developed my relationship with Dr. Crock, I asked you as well, like, is this something that you would do? And I think we both felt pretty strongly. We don't like to make decisions off of just anecdotes. We really believe in the scientific process and having good data behind what we're going to do if we're going to do a procedure that potentially could hurt someone. And stellate ganglion block, it's a pretty safe procedure, especially when done in the right hands like Dr. Crock's, but nothing is perfectly safe in this world. You are working right beside the vertebral artery. And so it's not something that should just be done if you don't have good data to back it up. And so when this started getting the social media presence that it got, and Dr. Crock and I started talking, the first thing we said was, why don't we just do a pilot trial? Let's just do a few patients. Let's see if it seems to have a signal. And then if it does have a signal, we can do more. And so we actually did a study that we published 2 years ago now. And that study was our pilot trial where we injected 20 patients who had primarily COVID-induced olfactory loss. So we were really focusing on hyposmia rather than parosmia. But as a secondary outcome, we did look at parosmia. And what we found was there was probably some signal for that group. In the 20 patients that participated, we found that about 50% noted at least slight subjective improvement in their olfactory dysfunction, with 55%, so 11 of the 20, attaining a clinically meaningful improvement on their UPSIT, which is objective smell testing. And 35%, so 7 of the 20, noting a clinically meaningful improvement on olfactory specific quality of life, which was done through our odor, which is the olfactory quality of life questionnaire. This wasn't great data, right? 50% is not, mind blowing, but it was at least a signal to say maybe there's something there combined with all of these social media stories that we're hearing. And so from there, we said, well, okay, we think we have enough to be worth our time and worth patients' time to really definitively do the randomized controlled trial.
And that being said, nobody had major complications from this. Again, these are blocks that I do all the time clinically, but that's in a different pain context, and everyone tolerated them well. We didn't have any major adverse effects. And so it kind of gave us the idea that it would be a safe kind of trial to proceed with. And there was nothing else out there that was even slightly effective. So we had some hope that maybe there was something there and that we could maybe figure out a specific population of patients that may benefit from this. And we really hoped to help them because these are patients, meeting every one of these patients, the stories are horrific. They're really struggling.
The next question that everyone asks us is, if your pilot trial was for smell loss, why was your randomized controlled trial for parosmia, which is smell change? Around the same time that we published our pilot trial, there was another study that came out, an observational study where a group out of Texas who was doing these at a very high rate was noting significant improvement in patients, but specifically they noted that the parosmics were the ones who seemed to have the greatest benefit. And so we had a lot of debate back and forth as we were planning our randomized controlled trial of should we look at hyposmia or parosmia or both. And the decision was that we would really focus on parosmia, try to have a very clean study. And then if we found something, then we would love to move forward and do hyposmia as well. But the patients that suffer from hyposmia as their primary symptom are very different than the patients who suffer from parosmia as their primary symptom, even though there's a lot of overlap of both symptoms in everybody. And so we really wanted to have as clean of a study as possible.
Yeah. So what's the typical protocol, or like, how did you, I know that they were randomized and I suspect blinded. Did you have any trouble with recruitment? Were people okay getting a placebo? And yeah, just walk us through, like, what did you find? Like, how did it end up shaking out?
So I'll let Dr. Crock talk about how it's done, but I will tell you recruitment was not a problem. People were very excited for a stellate ganglion block.
And, we had weighted it 2-1 with the active versus the placebo so that you had a higher chance of getting the active medication. And we did say that if we found a significant benefit, that we would offer the patients who got the placebo the active compound later. So we sort of had that fail safe, as if this is really great and really works, that we would step up and do this for you later.
Yeah, that's pretty cool. That makes it even more appealing, I think, for people. They won't be kind of left behind, right? Even though they put themselves out there.
And people came from all over the country. They were really excited. We had one person come from Europe. People were really motivated to get treatment because they're really struggling and suffering. And so the pharmacy actually blinded us to the drug. So the pharmacy would give me a syringe, and I didn't know whether it was the active mepivacaine versus the inactive saline. So I performed the same block on every patient, and we didn't become unblinded until the actual data analysis came through. So every assessment was completely blinded to what the patient's intervention was, which I think gives a unique assessment of whether or not it's effective.
One of the things that a stellate ganglion block causes is a Horner syndrome. And so it was actually very challenging to figure out how we were going to blind both the study team and the patients. And if you look at other data of randomized controlled trials looking at stellate ganglion block, a lot of them don't really, like they'll say they're blinded, but they're blinded in that they just tell everyone you could get a Horner syndrome regardless of which team you're in. So we did that, but we took it one step further and actually put a eye patch on patients on the side where they were receiving the block and a cold pack, so that not only could they not physically see if they were having an eye droop, but they wouldn't feel any weird changes on that side of their face either because of the cold pack.
And if you look at the adverse effects in our study, you can see that the, quote, adverse effects, which are common results from a stellate ganglion block, were much higher in that group than in the placebo-controlled arm. In addition, we didn't really focus on asking them those questions. Hey, do you feel your eye drooping? Are you, feeling, your face getting warmer? If they told us that they had it, we would mark it down. If they got nasal congestion or stuffiness, we would record it, but we didn't specifically ask them those questions. Part of it is a way just to, again, blind them and blind ourselves from the control versus the placebo arm.
Yeah, really thoughtful design. Really great. So how many people did you end up taking through the study, and what did you find?
We ultimately recruited a total of 32 people, which were randomized to the stellate ganglion block, and then 16 that were randomized to the placebo. So if they were in the stellate ganglion block group, they would receive mepivacaine versus the placebo just had a saline injection around their stellate ganglion. And we did actually randomize side of the neck as well, because in our pilot trial, we found that doing bilateral blocks, which is traditionally what is done for stellate ganglion blocks, we didn't find that adding a second block did anything to people's outcomes. And so, especially because people were flying around the country, again, you're not with zero risk when you do any procedure in this world. So we wanted to really keep it down to one side, but we did randomize sides so that if we did find a signal, we could look and see if there was one side that seemed to be superior to the other. We initially had planned to recruit 140 people, but we had a planned interim analysis after the first 40. Because of kind of time of injections, the analysis happened around 40, but we ended up having a total of 48 people available for data. And it was so profound when we looked at the interim data. Literally, the two groups were essentially identical. And when our statistician sent us that data, the entire team, I think, was pretty floored. We weren't sure if we would find anything, but we certainly didn't expect the groups to be identical. So it made it pretty easy for us to make the decision that we were done with the study, and we had a strong conclusion that stellate ganglion block, at least with a unilateral block with mepivacaine, was not useful for this population.
There's different ways to interpret the data in that both groups seem to have some improvement. And so there has been some criticism as whether or not the saline alone is an active placebo, which could be true. It's possible that the stellate ganglion does have some physical activation just by injecting saline around it. And so future studies may want to take that into account in looking at whether or not they couldn't blind it based on the procedure. So we wouldn't be able to be blinded in the same way. But if a placebo block, such as like a superficial block versus a deeper plexus block, would be another way that the study could be done. But based on the way that we had planned the study, based on our randomized control trial, the way that this was done, there was really no reason to continue it because there was no evidence that there was a difference in either group.
Something Dr. Crock and I did talk about afterwards when we came across this concept of an active placebo was that while you may get some activation of the stellate ganglion from even just some saline, our effects that you see between our two groups persist at 3 months. And you wouldn't expect that if there was some stellate ganglion activation from the saline that it would have as persistent of an effect. And so we still feel, even with that kind of question that's been raised, that our study has pretty clear results.
Yeah, and then just another technical question, Dr. Crock. Are these blocks that are sort of, when they're effective for other things, like you mentioned some of the other indications, is this sort of like a one-time thing, or do people have a series of injections or an initiation phase or a maintenance phase? It's not the same thing, but there is superior laryngeal nerve blockade in the larynx for chronic cough and things like that. It's been somewhat popular and a la mode in our specialty. In your world, do these sorts of procedures, is the idea of an initiation thing or maintenance, is that a real thing?
Yes and no, I think could be the answer. I think pain is such an art versus a science at this point, which may be very similar to many other fields of medicine, but we sort of do what we think is right for the patient based on how their symptoms evolve. So again, with injections, any type of injection, oftentimes there was this theory that you just kind of did them on a regular basis to prevent the pain from getting worse. And that has sort of gone out of favor now. But with stellate ganglion blocks, generally we do them in a series for pain. That being said, if patients get better after one block, I'm not going to do another one. So some people get one and it persists. Some people get one, it doesn't do anything. And this is specifically for treating, complex regional pain syndrome. So if they get no benefit or they feel worse, I'm going to be hard pressed to do it again. If they get transient benefit and the pain's starting to creep back, then we can talk about doing it again. But it's always that sort of balance in whether or not we would repeat it. It's a relatively safe procedure. And again, I do these all the time, but it is somewhat invasive. You're injecting up in the neck by C6 or C7, right where the vertebral artery comes out. You're putting it, right next to the carotid, under the IJ. There's a lot of other nerves in that area too. And so there are real risks and potential risks for it. However, I think it is considered quite safe. But I think at this point, lots of people are paying a lot of money to get these blocks done. And I understand that impetus because these are desperate people with a horrible condition. But at this point, I don't think we have good evidence to suggest that it would be worth that money.
And I think we have to remember how important it is that these people are desperate, right? I think it's essential that anyone who's considering doing a procedure like this in this population, the COVID-mediated olfactory dysfunction population, I think it's important that you have a lot of insight into yourself and your own practice, and that we don't want to take advantage of a very vulnerable population. And that's what these people are. They're desperate to feel better, and we are desperate to make them feel better. But that's why we have good evidence-based medicine to make sure that we're doing the best thing for the patients.
Yeah. Yeah, I mean, it's also like, to your point, we want to help. It's also disappointing when you're maybe trying something that isn't going to pan out or is unlikely to pan out. So a really important contribution to the literature. I really commend you both. I'm excited for the readership to take a look at your work and the contribution that it's made. So thank you both.
Thank you so much. Yeah.
Thank you.
Well, I'm Paul Bryson, and I've been speaking with doctors Nyssa Farrell and Lara Crock from Washington University regarding stellate ganglion blocks in COVID-induced parosmia. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.